Okay, so hey guys, this is my first video, okay, of medical, and I'll be talking about the primary open angle glaucoma. I'll be talking about the signs, symptoms of this. Okay, so first we'll start with the symptoms. Okay, what happens in symptoms? First of all, I made a story. I just made a story. It's an imaginary story. Okay, you can just imagine. So what happens? There is a child, okay, who is in the dark room and he's trying to study but he's unable to read and learn. Okay, and this results in a headache, eye ache, and there is significant loss of vision, blindness, and scotum. Okay, so this is the story, and the symptoms from this we can classify that the patient may be asymptomatic. Okay? You have to be you have to be this is very important to note. Okay, the patient may be asymptomatic. Okay, right. Then second is there's a difficulty in reading and close work, as we said earlier. There's a delayed dark adaptation. Now he's in the dark, so he's in the dark. There's a delayed dark adaptation occurs. There's a headache, eye ache occurs, significant loss of vision, blindness, and scotoma may be noticed. Okay, in the optic disc defect. Okay, so these are the main symptoms of the primary ophthalmic glaucoma. Okay, so now we talk about the signs. Okay, signs is very, there are four main categories in which we have described the sign. First is the anterior segment sign. Okay, then there's the IOP changes, there's the optic disc changes, and there's visual field defects. Okay, there's the four main changes. Okay, so first we'll talk about the anterior segment sign. Okay, the anterior segment sign generally it is generally normal. Okay, it is normal, but in the later stages the pupil reflex may be sluggish. Okay, and the cornea may appear as hazy. Okay, that's anterior segment. It's not very specific, but they can be there. Okay, the second is the intraocular pressure change. That's very important to note. That's the intraocular pressure changes. Now exaggeration of normal diurnal variations. Now what happens? The diurnal variation is very normal in normal people, but in the glaucoma patient there is exaggeration of this diurnal variations. Okay, and this can be tested by the diurnal variation test. Okay, and in evening the IOP falls down and it has to be noted that reverse happens in the angle closure. That means in evening the IOP rises in the angle closure and in open angle it falls. Okay, so this was the intraocular pressure changes. Okay, now we talk about the optic disc changes. Okay, optic disc is very important. It is progressive, it is asymmetric, and has a lots of variety in its patterns. Okay, we'll talk about this. Now we talk about we see that there is examination technique of how would you examine the optic disc. Okay, so there is a stereoscopic view of the optic disc with contact or not contact lens on a slit lamp biomicroscopic examination is done. Stereoscopic view is most preferred one. Okay, and then we have the documentation technique, and here is the HRT. That's Heidelberg retinal tumor. I'll show you the picture. How does this look? So that's the Heidelberg retinal tomograph. As you can see over here, this is the Heidelberg retinal tomograph, and it is used for the documentation technique. Okay, so you can see this is the Heidelberg, right? Okay. Okay, done. So now we talk about the glaucomatous changes in the optic disc. Okay, right? So there are changes. I mean, there are stages. Okay, so first stage is the early glaucomatous change. Okay, so here you can see I just made a schematic representation. It's not actual, or it has no how it has no. It's not actually, just to remember. Okay, so you can see that. This is the optic disc. Okay, and this is another optic disc of the another eye. Okay, so here what happens, there's a selective loss of the neural rim tissue. That's on the pole. There's a superior pole and the inferior pole. There will be a selective loss of the neural rim tissue, the selected neural rim tissues. Okay, and there will be splinter hemorrhages. Okay, splinter hemorrhage, you can see the blood drooping down. Okay, I just made it for fun. So that's splinter hemorrhages. Okay, you can see on the margins, and then there will be atrophy of the retinal nerve fiber. This is the retinal nerve fiber. There will be atrophy, will start from here. Okay, and there will be paler areas. These are all the paler areas, right? You can see this is all the paler areas. Okay, and I have drawn the other one to show that there is an asymmetry of the cups in the two eyes. So it's asymmetry. Okay, so that's the early glaucomatous changes, right? So now we see the advanced changes. Advanced changes are very important. Okay, here first of all, there's a marked cupping. As we say, there's a marked cupping of it's a cupping of the optic disc. Okay, then there's a thinning of the neuroretinal rim. Okay, there's a thinning of that neuroretinal rim. There's a neuroretinal rim which it gets thin. Okay, and then there's a bio-knitting sign. I'll show you what is bio-knitting sign. It's very important bio-knitting sign and very characteristic for the glaucoma. So you can see here. Okay, you can see here. So this is what happens in bio-knitting sign. There's a shifting of the retinal vessel occurs. There's a nasal shifting of the retinal vessels, and the vessel starts to broke, and the hemorrhage is also seen. Okay, hemorrhage is also seen. This is a bioneting sign, is very specific for the in advanced stage of the glaucoma. You can see that there's a nasal shifting. Okay, right. And the another pathognomic sign, which is very important. Okay, and that's the pulsation of the retinal arterioles, right? Pulsation of the retinal arterioles of the disc at the disc margin, right? And it's a pathognomic sign of the glaucoma, pulsation of the retinal arterioles. So now we talk about the optic atrophy. Now this is the third stage. Okay, and in this what happens is all the neural tissues, okay, all the neural tissues of the optic disc are destroyed, completely destruction occurs. Okay, the IOP rises and it disturbs the exoplasmic flow also. That also damages the optic nerve. Okay, and the ischemic atrophy of the vessel also occurs in this. So there's the optic atrophy. Done, bro? Okay, done. Fine. Okay, so now we talk about the visual field defects. Okay, visual field defects is the very important and characteristic feature of this. Okay, so what it says that if 40% of axons are damaged and the visual field starts to occur. So when there is a 40% of axons are damaged, the visual field starts to occur. Okay, and there are types. So we'll talk about the types also. Now here you can see this is isopter contraction. This isopter contraction is non-specific for glaucoma. It's not at all specific for glaucoma. Okay, isopter contraction. And here what happens? Now these are called the isopters. Okay, these are called the isopters. Here is a fixation point. Okay, so these are the isopters. And what happens is the contraction of this isopters occurs. So here the contraction occurs, and also the field starts contracting, right? So this is the initial state. Then next is the badding of the blind spot. It's also non-specific, and the blind only remember that blind spot does not come in the field. That's all. There's nothing much to remember in that. Okay, then the main and the most specific first change in the visual field defect which occurs in glaucoma is the paracentral scotoma, right? So in this what happens, that this is the fixation point, right? This is 10, 20, 30 isopter. Okay, so what happens, the paracentral scotoma, this is the paracentral scotoma which present between the 10 and 20 degree. Okay, that is the scotoma appears in this area. That's a paracentral scotoma, and there's a blind spot also. There's a blind spot done. So this is the paracentral scotoma, right? This is first specific sign. Okay, then what happens, cedral scotoma. In the cedral scotoma, so what happens is a paracentral scotoma